Ask everyone to stay in place for 5 minutes. We'll have a question and answer. If you get up, it's disturbing. Come on over, Rob. The other is Professor Coleman and I, at least I have a conflict with the latter section. I just want to be transparent in that I've served as a paid advisor for InBioMotion and have stock options. And Rob, I'm not sure what you have or don't, but okay. Rob is saying he does as well. We just want to be transparent about that.
So I think Dr. Bernstein has a comment.
Yeah, so I'd like to explore with my colleagues here this issue of the premenopausal women in the Taylor X study and the scores in the 16 to 25 range, how much benefit we really think is from chemotherapy versus ovarian suppression effects. And it's something that, at least in the States where we are commonly ordering the recurrence score assay, has really emerged as a major clinical discussion point. And I'll put my cards on the table and say that I don't think that a breast cancer in a 45-year-old premenopausal woman with a given recurrence score is fundamentally different from a 55-year-old woman with the exact same stage and recurrence score. And so my explanation has mostly been centered on the role of ovarian suppression, but I wondered if you guys had additional thoughts on this.
Angelo, do you want to start?
Well, if I have a premenopausal patient, let's say, in my Monday morning practice, who has a recurrence score, let's say, of 18 or 20, whatever, my first task would be to provide to this patient the best adjuvant endocrine therapy. And based on the data that Prue has presented, in my opinion, this patient should be treated with ovarian function suppression therapy plus an aromatase inhibitor. Having said that, I'm not saying that I would not consider at all also adjuvant chemotherapy, but I think this would be a point of discussion with the patient. I am not entirely convinced that because of the subgroup analysis that has been presented in Taylor X, all of these patients have to receive adjuvant chemotherapy. This is my personal point of view.
I guess I have a bigger concern in the very young women, the women under 35, with none of the multi-gene assays have I seen sufficient information for this very young age group to really feel confident that if you come out with a low-risk score, because so few of the women in the trials were very young, and we don't know whether they got ovarian suppression or they didn't. So I think the whole premenopausal area, particularly the very young, is a bit complex with these multi-gene assays. I think we have insufficient data in premenopausal women. A number of the assays were actually validated in postmenopausal trials. And so if you have those, risk prediction algorithms and curves predicting distant METs at 10 years, they relate to postmenopausal women. So.
Dr. Weiner wants to join in the conversation.
But I would argue that there's probably a similarly small number of those patients who were ever in the large randomized chemotherapy trials, such as NSABP B13 or the studies that establish benefit in node-negative patients, or B20.
Can I add to that? One other issue is the responder trial will be reporting out sometime in the next decade. It goes back to what Angela was saying, it's taking forever to get report outs now because patients are doing so much better. I guess, Hal, you're the one who said that, which is a wonderful problem to have. But that will help us decide if chemotherapy actually is helpful in patients with a worse prognosis but have a less than 25 recurrence score. In other words, maybe it just doesn't work, and in that case it's shutting off ovaries and not hitting the cancer cells.
Well, if you look at the data from the TEXT no chemotherapy cohort, which had just over 20% node-positive patients, all of whom received ovarian suppression, there's very few distant recurrences still in that group. So, it probably is possible to find a group of patients either without a multi-gene assay or with a multi-gene assay.
Well, and that's part of my argument, which is I think if you look at that cohort, that looks very much like what you would have expected those, particularly women in their 40s with the low-risk scores to look like.
We need to call it.
Yeah. One more comment.
Very quickly, I just wanted to say that luckily we are still living in a time in which At the end of the day, despite all this technology, despite all these nice scores, we still need to discuss with our patients. Because, in my opinion, the results of TAILOR-X do not provide a definitive word about how we should treat these patients. I think that the discussion with the patient, the fine-tuning of the treatment may also be based on understanding patient needs and expectations. And we are all sitting here, we are all clinicians, and we all know how much is important understanding the patient needs. That may vary from a patient to another. So probably we will continue to work for the future. It's not entirely true that we will be...
We should all have Ann Partridge come to our clinic and talk to our patients.
Why not?
I think with that comment, it's important, I guess, the sum of that is that no one trial can be taken out of context. Just as we look at the softened text and then put it into the TAILOR-X and say, well, it wasn't adequate hormonal, we have to put all of these trials together in context, and we have to look at patient preference. So I'd like to thank the panel and my co-chair and all of you for staying. We'll have a brief break, and then there's the last session of the afternoon.
I'd like to talk.